Um,
Good evening.
I think you should be good to go whenever.
Wonderful. Well, welcome, ladies. Everyone's headset's working. Everyone can hear everyone. Now, welcome to the Urogynecology Journal second Instagram Live. We have some really wonderful guests tonight. We have both Dr. Amy Park and Dr. Yurteri-Kaplan, who are going to be chatting with us for the next about 30 minutes or so about ergonomics and surgery. Thanks to all of you that have hopped on to join us. I'm going to turn over the microphone for a minute to Dr. Amy Park so she can tell you a little about herself and how she got interested in ergonomics.
Well, I want to thank Dr. Meriwether for inviting me and Dr. Yurteri-Kaplan, as well as as OGS, because I think this is a great opportunity, and also it was a great opportunity for me to learn how to do Instagram Live, because I don't know how to do this. So thank you for remediating me. So in any case, my name is Amy Park, and I'm the section head of Urogynecology at the OBGYN and Women's Health Institute at the Cleveland Clinic. I became interested in ergonomics because when I was young attending, I basically was doing a bunch of surgery, and I could not lift my right arm past like the horizontal. It was very difficult for me to put a purse on, and I just remember thinking, I am 35 years old and I'm the primary breadwinner of my family, and I don't know if I can operate. And it was terrifying, actually, for a moment. I told my parents that I had this problem, and they told me I had Korean shoulder, which is like a narrowing of the acromioclavicular joint. But now that I'm older, I realize just everyone has this problem at some point. And to Dr. Yurteri-Kaplan's credit, she was my fellow, as you were my resident.
I was.
Yes, you're my former trainees, done good. So Yurteri-Kaplan and I did a study together looking at the proportion of awkward postures in vaginal surgery, and mostly she collaborated with this other team. And I'm going to transition to her to talk a little bit more about this project, but she also collaborated with the Mayo Clinic on another ergonomic project. So I couldn't be prouder.
Thank you so much, Dr. Park. It's a pleasure. And again, thanks for really highlighting, I think, something that we are aware of, but definitely need to put a big spotlight on this issue that I think oftentimes we just, are used to putting ourselves second or third or fourth. But thanks again for highlighting that. I'm Dr. Ladin Yurteri-Kaplan. I am a section director of Urogynecology at Columbia University in New York City. And I was Dr. Park's fellow, which she actually did get me very interested in this topic. I think, we were talking about this, and she said, hey, I think you need to study this more, because obviously we don't really know much about it in urogynecology, in gynecologic surgery, and in particular in vaginal surgery, which we do spend a lot of time doing. And so that's when I started thinking about it and trying to pay attention to what are these positions, what is going on in the operating room that's really causing strain and muscular discomfort. As a urogynecologist, we treat a whole variety of different pelvic disorders, but really these musculoskeletal and work-related disorders are not particular to surgeons, or not even particular to the healthcare field. But I think it's prominent in the healthcare field. And I think now, as we spend more time learning about it, talking about it, we realize really these positions that we put our body in may ultimately cause a lot of wear and tear. So even though we're urogynecologists, this could occur actually in any type of industry and field, and even with any type of surgeon or healthcare physician.
Well, thank you both so much for taking this topic on and highlighting it, not just for surgeons in general, but for women's surgeons in particular, because I think that's so important. And for those of you who are looking for extra reading, Dr. Park put out a wonderful journal article that's a review, and it's actually highlighted by our maintenance of certification, I believe, and will be in the coming year. It appears in Urogynecology Journal, which is OG's official journal. So Huge props to both of you for your publications. So for our listening audience that's not medical, how would you explain what the heck ergonomics is to someone who's not medical, doesn't come from this background?
Well, I'll just start by saying ergonomics, ergos is work, and then nomos is natural laws, and it focuses the idea of fitting humans to tools. And it was first coined by this Polish scientist, Wojciech. I cannot pronounce the last name, but it's like Gastrobowski in 1857. And it's a concept of designing the working environment to fit the worker instead of forcing the worker to fit the working environment. Really, it's gained more traction during the Industrial Revolution. And there's a lot of recognition that the awkward working postures led to health issues. And I'm just going to pass it off to Ladin to talk about her collaborator, Vic, who actually was just telling us that there's all these studies on firefighters and people who do computer work, but there weren't any studies on people who did on surgeons or proceduralists.
Yeah, other lifesavers, pretty bananas.
So this is actually a study onto itself in terms of ergonomics and the workforce. And, there's even a federal division, OSHA, that looks at specifically workers, work environment, safety, and, a safe work environment. It's really important. And it has been studied in many different industries, whether it's construction workers or industrial workers. The other day we had to have someone cut down a tree. How do you cut down a tree safely and do that without injuring yourself? Those are important things to know. But Amy's right in the sense that there wasn't as much done in terms of surgeons and the ergonomics of a surgeon, and even less so in gynecology. We do have some, emerging literature. We're learning more about it in, for example, open surgery and laparoscopy. There's very little in just GYN, vaginal surgery, and in particular, the procedures that we do. But ultimately, what we did was we found this amazing collaborator who was an ergonomics expert, and we started to design a study where we could actually quantify the problems that maybe all of us know about, right? After we leave the operating room, you feel sore. Your neck hurts, your back hurts, your shoulder hurts, your hands hurt, because we use our hands in our day-to-day jobs. And so why do these areas hurt, and how can we prevent the pain? How can we make it better? This is what we started to question. And so I think the challenge is how do you study this in the operating room? It's a really unique place. Unlike maybe car lines where they can watch and observe industry workers in that space, they can really get close and observe things and kind of quantify, even maybe put different external devices to measure strain on muscles. You can't really do that in a sterile environment in the operating room. So we had to come up with ways to be able to quantify this from an objective standpoint, as well as integrate that subjective pain that maybe the surgeon is experiencing. And so we work together to really do that.
That's awesome. And, what challenges do you find out about surgeons that you didn't know before this study?
I think, as surgeons, we spend our whole careers focusing on the patient, right? Which is what we do. We are trying to make other people's lives better. And so I think in that process, we oftentimes are not aware of what we're doing at the time. And so one of the challenges are that if you're in pain, for example, you don't really notice it and you just work through it. That's kind of the nature of our work and our job. And so kind of getting that subjective feedback as well with the surgeon actually doing surgery is hard to do, right? They're not going to stop and tell you how they feel. The other thing is you see them in a funny position, but being able to measure that. We wear gowns, we're in surgical gear, we're wearing sterile gloves. People cannot come close to us to be able to actually measure maybe the neck angle or potentially measure the muscle strain with a device like, for example, EMGs. And so those were some of the challenges of being able to kind of monitor and measure those different things.
Gotcha. Why do you ladies feel like now is a vital or a good time in history for us to be paying attention to ergonomics in the operating room? Like, why now? Why not 20 years ago or 20 years from now?
Well, I'll take a which is I think there's been a lot of people who have been interested in surgical ergonomics over the years, but now with the focus on wellness and burnout, I see the culture of surgery and surgeons changing. As Dr. Yurteri-Kaplan alluded to, there's always been an ethos of silent suffering and of ignoring pain, either emotional or physical. But as we've gained the vocabulary to discuss issues of wellness and burnout, we're able to discuss the physical challenges and sequelae that surgery imposes on our bodies. There was a JAMA surgery meta-analysis in 2017 examining the burden of disease of work-related musculoskeletal disorders among proceduralists and surgeons. And it was about 12% reported career modification, disability, or early retirement, which I think is an underestimation. And if you look at the point prevalence estimates of cervical, lumbar, or thoracic pain, arm pain, shoulder pain, those estimates are quite high over the prior 12 months. It's like in the range of 20 to 50% essentially. And I would say that the pandemic has only exacerbated existing workforce challenges, with physicians retiring or at the other end of the spectrum, grappling with inadequate childcare and curtailing their work hours or careers at the same time that there's a large demographic bulge of aging baby boomers that require care. I personally know several people who have undergone PT or are disabled from a work injury or had major disc surgery and back issues and were out of work for a while, or have had to modify their operating schedules due to work-related musculoskeletal issues. Interestingly, speaking of social media, I actually connected with like-minded folks on Twitter, and essentially I'm a founding member of this multidisciplinary society called the Society of Surgical Ergonomics. And we came together with a common interest and concern around surgical ergonomics and the burden of work-related musculoskeletal disorders in surgeons. And the society has been quite successful in moving the needle in terms of awareness and attention to this issue, and is having its first research symposium this Friday virtually on September 23rd. And the American Journal of Surgery will be the meeting journal. Many of us have been giving grand rounds and writing review articles. Like I wrote this one in Urogyn, and then Ladin and I also wrote another one that we've submitted to a journal. And we've been engaging with various stakeholders. This surgical ergonomics has been added as a score module for general surgery residents, which is analogous to our CREOG curriculum for OB/GYN residents. It's one of the wellness interventions in the second study, which randomized general surgery programs to either a control group or wellness interventions. It's also spawned an ergonomics committee at the American College of Surgeons. But the surgeons, like I alluded to earlier, they're multidisciplinary, and there are urologists and ENT physicians and general surgeons and lots of different fields represented here, neurosurgery, orthopedic surgery. So I think there's a lot of opportunity and just heightened awareness. And I think just as people didn't have heightened awareness of not suffering from pelvic floor disorders anymore, like a lot of patients come in thinking, oh, urinary incontinence is just something you deal with age. I think surgeons now have the awareness, like, I need to really pay attention to my body because I need to preserve my career. Like I can't not operate, you know, at the age of 45, which is a lot of the onset of a lot of these disorders. I mean, I know people who just started their careers are in PT. So it's like scary to have these issues with that preclude you from being able to practice your craft that you've trained all your life for.
Yep. And teach that craft to others, right? Just when you're becoming a surgeon that has so much knowledge to pass on, to be disabled or to be unable to do that. It's such a shame.
I don't think, and I think we're all aware, right? This is not a new concept in terms of, we are all aware that there's a degree of wear and tear physically, and also that equates to mentally, right? When you're in pain, you are obviously not as focused, you're more stressed. So that's not something new. I do think the culture is shifting. And as we realize that, you know, you spend all of this time training, all of this education and investment, both financially and, you know, mentally in your future career, to have it curtailed because of an injury or a wear and tear, that can be devastating. And so I think the paradigm, that culture that Amy was talking about, really has shifted, where we are now looking at the surgeon, or we're looking at physicians as a whole, you know, that balance in life. And that also involves, in the same hand in hand, prevention, to prevent injuries and to sustain a long career, so that we don't have burnout and we don't have people leaving the workforce when we know we're going to be short supply, you know, in these next 10 to 20 years.
Awesome. And since our host is the American Urogynecologic Society, what additional problems do we face, or challenges do we face as urogynecologic surgeons, or gynecologic surgeons specifically?
I can take a stab at that. I think that we are unique in a sense that we really do have a multi-system approach to the disorders we treat. We can provide surgery in many different modalities, whether it's vaginal, whether it's laparoscopic, whether it's robotic. We're very versatile in that sense, or even cystoscopic. And being in these different modalities, there are different strains in the body for each one. And so we might actually be at risk for more than just someone who, for example, always does open surgery or always does a certain type of laparoscopy. And so I think that because of that, it's even more important, more paramount, that we really study and evaluate musculoskeletal disorders with all different types of modalities and approaches we provide.
Absolutely. And which is why it's so amazing to hear Amy talk about collaborating with surgeons from different specialties that have this expertise and experience with entering the body through all sorts of routes and with all sorts of organ approaches in mind. That's really a neat base of knowledge to create mutually with them.
Yeah,
So,
I would say, I would just like jump in and say that, you know, it's like the yin and the yang. I mean,
yeah.
we do practice a variety of approaches: the vaginal, conventional laparoscopic, and robotic assisted laparoscopic surgeries. Some still practice open surgeries. I think each modality has its own challenges, but the static positions, poor posture, lack of physical awareness are common risk factors across surgical approaches. And then the good news is we can do different approaches. It's like doing a different kind of workout and cross training at the gym. But I think particular to OBGYN and urogynecology is the fact that most of the surgeons are now female, and women are noted to have more strain, particularly associated with the use of laparoscopic instruments, which are not geared towards smaller hand sizes. And the studies, many studies show an association of smaller glove size, less than 6.5, with increased strain and discomfort.
Well, it's good to know. And as our workforce is becoming increasingly female in medicine and in surgery, we really have to pay attention to the wide array of body sizes and types that are entering that field, where operating rooms were designed for men that were tall. Traditionally, that was just the way it was. We're kind of behind the 8 ball in our work environment, matching our workforce. So let's talk about some solutions that you all have learned or heard about or are proposing. So what are some best practices that we know do work to prevent us from ending our careers or our full work spectrum early?
Yeah, I had the opportunity with our study to really look at vaginal surgery. And I think Amy hit one of the biggest points, is that anything that's static can really put a lot of strain. So we were particularly looking at primary versus assistant surgeons. We also combined and looked at our data of sitting versus standing for vaginal surgery. And if you're in a static position, kind of holding a retractor, putting force, especially if you're in a non-neutral position, that's going to put a lot of strain. And you probably will recover after that surgery, but you can imagine if that repetitive injury occurs over time and more often and frequent, that recovery process becomes smaller and smaller, and then ultimately leads to a permanent injury. So anywhere where you can change position, for example, if you're an assistant, changing from the right side to the left side of the body can make a big difference. If you're the primary surgeon, oftentimes we gear everything toward the primary surgeon. If you're vaginal, the height of the table when you're sitting or even standing is potentially based on the primary surgeon. you have to be mindful of your assistants too, to equate that height. Maybe the tallest person should be sitting and maybe the other ones should be standing if you're doing vaginal surgery. If you're at the table, then the table should be to the primary surgeon and everyone else might need to be on a stool. So those are kind of some of the simple things to do. The other thing I really liked, which I kind of started incorporating into my practice at least, was doing these micro breaks. And I think at the Mayo Clinic, they've done a lot of, looking at these micro breaks. There's a whole team of ergonomists that work with surgeons and healthcare providers. Every 20 to 40 minutes, right? Stopping and doing a stretch, whether that stretch is maybe 30 seconds to 60 seconds. It doesn't necessarily impact the time of the operating room, but ultimately what it does is it stops that static posture. So if anything I can say taking away, avoid static postures for prolonged periods of time, changing position, taking a break maybe every 20, 40 minutes. And it might not be feasible to do, honestly, every 20 to 40 minutes, but often in the operating room, we're doing a case and there's natural breaks at the procedure, right? Natural portions of the procedure where you're changing things. That's a time everyone should stop, stretch, stay sterile, and then start again.
Yeah, I would just emphasize everything that Dr. Yurteri-Kaplan mentioned in terms of maintaining a neutral position, avoiding awkward postures, adjusting the table height to 80% of your elbow height, using the Trendelenburg to your advantage in vaginal surgery, keeping the monitor at eye level. You want to avoid the neck flexion for being more than 20 degrees, especially when you're using loops. It can be very difficult. Adjust table heights adjusted to the tall surgeon. I actually adjust the height to the middle surgeon on vaginal surgery, but and then you want the working angle between the laparoscopic instruments to be about 60 degrees. If you're doing robotics, having a lumbar support for your chair, and don't use a rolling chair. Don't press your head too much into the console. And then exercise, and especially core strengthening exercises. And then trying to help your trainees, because they just don't have, they're just concentrating on other things. Cognitively, they cannot concentrate. And that's one of the things that we really can pay it forward by helping them with exposure and avoiding these awkward postures, and then appropriate rest and recovery. And I think one of the things that I actually really liked was this op-med doximity article by this plastic surgeon. His name is Dr. Jonathan Cabin. And it was called Surgeons Are High Performance Athletes. And he extolled the importance of enough sleep, exercise, appropriate equipment, mindfulness, what he termed relaxed focus, visualization, like doing the, I think actually UNM did a bunch of this visualization work. Thanks, Andy, for the shout out. Teamwork, rest and recovery, and streamlining in order to avoid decision fatigue by outsourcing, and it frees up the time and space in order to gain improvement in performance. So I think just trying to, just like athletes do, I think we just need to be more in tune with our bodies and treat the bodies at the temples that they are. And oh, perfect. Thank you so much for putting that into the chat. And then just really paying attention. I mean, if you don't have a good diet, you're not going to have peak performance. So personally, I try and have like more high fiber and protein diets on my surgery days, because if you don't eat a lot of carbs at lunchtime, I'm just tired, and that's not fair to the patient. So taking stock of what works for you. If it's at a big breakfast, have a big breakfast. If it's not having a big breakfast, don't have a big breakfast. Things like that. What works best for you. And then making sure that you have enough exercise in your life is super important. So
one of the craziest things that I've done regarding ergonomics is that I drink a ton of water, because I found that being dehydrated makes me more stiff and want to stay in these static positions and I'm not as energized. It also gives me the perfect excuse to do micro breaks because I can say, okay, well, we all need to take a bathroom break, or one person's going to take their bathroom break 2 hours in this natural break. So as strange as that sounds for your gynecologists to say drink a lot of water and pee more, I found that it's avoiding static position.
I remember Amy, telling me back in fellowship about this article and really talking about like, we have to start thinking differently. We have to start thinking like athletes, right? Not only are you mentally focused, and I think most of us are really good at the mental aspect because, right, we've done that all of our medical careers. We've thought and studied and trained from a mental aspect, but I think the physical aspect is something we are not good at because we didn't really ever think of this as a, hands-on activity. But obviously surgeons, that's what we do. We use our hands and our bodies to help people because we're fixing them physically. And so that change in thought to me really kind of clicked in terms of, okay, I need to prepare not only mentally, but physically, whether that is, getting more exercise and sleeping the night before and being ready to be at my top performance so that I can handle anything in the operating room. And sometimes that little micro break, whether it's 60 seconds, can reset, change your focus, and then can get back into what you're doing. And it really actually can be more productive.
Absolutely.
Actually, I was just going to jump in and say, the studies show that there's about 34% improvement in mental focus, 57% improvement in physical performance, and up to 70% improvement in physical pain. So it's actually, not only is it not detrimental, it's beneficial to physical and mental acuity in the operating room. I'm still bad at it. I mean, there's like an app that you can use and I just forget to use it. But at the same time, I do think that there's the thing about Urogyn, there's all these little discrete parts of the procedure. There's the vagus, 30 minutes. There's the self-injectomy. There's the uterus-sake. There's the anterior repair. There's the posterior repair. And all of them are kind of like 20 to 30 minutes. So I find it more useful to think about these little discrete portions as like natural breakpoints, as opposed to like the time, because the time just, it just
flows.
It flows. Yeah.
And I agree. And I looked at the educational course, that curriculum on Mayo to see what exactly are they stretching. Mm-hmm. And I was like, and at the end of it, I thought, okay, there's no way I'm going to remember all of that. So we did that natural break. Let's stop and then just stretch our neck, stretch our shoulders, stretch our back, stop the flexion. I think naturally sometimes I have a tendency to hunch, right? You might be more aware of what your natural tendency is so that you try to readjust to kind of prevent that.
That's awesome. And I love the concept of, let's dispel the myth that anything that adds 15 seconds to the procedure is naturally detrimental, because I think we're all so aware of resource utilization that we're worried that if we add 15 seconds there, we're going to harm our patients. And at the end of the day, we might be doing not just a service to the patient that's in the operating room that day, but a service to the dozens of patients we can serve at the end of our careers when we're not harmed. So that's amazing.
Or even to the end of your surgical day, right? You're in a different place at the beginning versus the end of the day. And if you can maintain that acuity throughout, you're doing a benefit.
Yep. One of my trainees who's watching, Dr. Hobson, is mentioning in the chat that in fellowship, where she was my fellow actually, started doing yoga prior to our longest cases, which were our straight stick laparoscopic sacrocolpopexy. I'm glad to hear that worked for you, Deslin. That's great news. I find that the stretching in advance of a long surgery is choice. It's really great.
Absolutely.
Are there sort of don't do's that you doctors that are our guests tonight want to talk about, like common things that we do every day that we think are good for the patient or for ourselves, but we probably should avoid?
Well, there's certain things that are risk factors in any field. Like we discussed at length, avoiding the static posture, but activities with vibrating tools, I think that's more probably applicable to like orthopedic surgeons. But exposure to cold, repetitive activity, and then, prolonged repetitive exertion that's greater than 30% of the operator's strength. And then these body segments held in extreme positions. So, I mean, keeping a Breisky up like this, for several hours is not healthy. So I tend to relax it in between, and then I bring it down and I pull it up. But I think also, the just being really conscious of the cervical spine issues is super important. But have physical awareness, correct your trainees' posture, positioning of themselves and the patient and the surgical field and table are of primary importance here.
I also think, once you're in the middle of things, sometimes it's hard to see what potentially might be problematic. But before you even start your case, obviously positioning the patient, Amy had mentioned, is a big one, but potentially looking at the field, right? Looking at the surroundings. If you realize there's cords all over the floor and you're going to be ending up stepping, kicking, moving them as you're operating, adjusting that prior to even starting the case, adjusting the lights so that they actually expose, so that you're not cranking your body in a way to then, see better. Taking note of the surrounding, taking note of the level of the screens before you even start the case. These are things that I think you can do, maybe not don'ts, but do beforehand so they can get rid of the don'ts, the ones that might actually end up making a problem where you can't focus. You're not even noticing the cord when you're in the operating room, right? And you're actually doing the procedure, but beforehand you could notice it and move it out of the way.
I will add to, in terms of OR efficiency, I like to, as soon as there's a lot of waiting around as the patient goes to sleep, and then, you're waiting to position. So as anesthesia is intubating, and pushing the drugs, etc. I just, that's when I get the foot pedals and the step stools and the lights and the all of those things, that make sure that the stirrups are in place, get all the foam that I want to pad, and this should be part of your surgical checklist. I think is to use that time. It's like 5 or 10 minutes. You can just use that time to check on all of these things. Because it is a lot of hurry up and wait, and then go when you're positioning, and just making sure that all of those things are in place while you're waiting. It's like you might as well, you're getting the kit ready. Mm-hmm.
I was actually thinking about it last night, those anti-fatigue mats. I'm like, what if we just had shoes that had that, right? The built-in anti-fatigue that would help, so that as you move, it's moving with you. And I'm sure there are obviously shoes that make a difference too, TED stockings to prevent that lower extremity edema and discomfort. Those are also simple things to do that can help for you as well. Maybe we should design that, or maybe there is one and I just haven't found the right shoe. I don't know.
I need one of those
you could step on to kind of stretch your
oh
feet.
Yeah,
that was neat.
Totally.
I love it. I also really love that concept that you just introduced of using what I call the AMAT, the anesthesia messing around time, to get everything ergonomic that you can control prior to that, focusing all that energy on the patient, positioning them. We put so much into positioning patients because we know it's important for safety, but we don't put as much into ourselves. So that's a great culture change. Are there big questions that you ladies have, you've heard from your fellows about? What do we want to know about ergonomics in urogynecology in particular, or more broadly in surgery? What are some big unanswered questions that we need researchers and the field to seek out the answers to?
Well, I think the current data are limited because they're subjective. As Dr. Yurteri-Kaplan alluded to earlier, they're cumbersome recording devices. We're hampered by the sterility of the OR, and then there's a lack of validated correlation between subjective reporting of injury and objective finding. I mean, at this point, we can't even say laparoscopy is associated with cervical spine injury. You know what I mean? Or anything like that. So it's just, you can't even correlate what we're at risk for right now. We need instruments that are reproducible, easy to use, and objective. We need to target surgeons at every level of training. And then we need to correlate symptoms of pain or discomfort with the findings of ergonomic assessments. And then, it would be cool if we could look at tissue level damage. Although I don't want a muscle biopsy, so I don't know how we would do that. But and I don't think EMG is actually very accurate. I mean, just doing urodynamics. I mean, you guys all know that the EMG is not that helpful. It's usually not good. So, but I think that I saw a Mayo Clinic ergonomic assessment with they had these sensors, like using the sensor data. I think I want to see technology driven solutions and measurements. And I'm hoping that there's just so many data points. I'm wondering if we could leverage AI and machine learning to help us arrive at these questions or the answers to these questions. And I'd love to have some more data on what actually works, because these are educated guesses and analysis, expert opinion analysis of best practices. The micro breaks actually do have pretty good data to support it, but the other stuff is based on basic ergonomic stuff, just keeping everything in neutral position, 90-degree angle of your elbow, not doing too much, awkward positioning. But I think that, nobody's ever looked at in vaginal surgery, you've rotated your elbow too much and your shoulder is too abducted and rotated, that kind of thing. So I think these are areas yet to be elucidated.
Yep. And even of the claims that are made by high dollar companies, I mean, we all know I'm talking about robotics companies, that they say that the use of their tool is more economic. We think practically they may be correct, or it may elongate the careers over, say, straight stick laparoscopy. We haven't demonstrated that yet. So there is some low-hanging fruit that could be looked into.
I even, it's funny because I was in the other, the operating room the other day doing robotics, and I definitely, because I'm a smaller stature, that stool is larger. The stool ends up pushing on my thigh. So after several hours, I had to stand up and my legs were numb. And you can imagine over time, that's obviously going to take an effect. So even with robotics, there's definitely strain on, lower back because you're sitting. If your posture is poor, obviously strain and potentially neuropathy down the legs and so forth. But the thing that I'm most interested is kind of two. One is there a threshold, right? Is there a threshold with, you've done X amount of case this way and ultimately you are going to cause this injury? And that's probably a really hard question, right? To determine if there's a certain threshold of doing a certain procedure. So for, a period of time, will you permanently cause injury? And if so, what is that threshold? The other thing is there a potential for a reversal? Once these injuries have occurred, by doing some of these different things we just talked about with the micro breaks or with readjustment and being more mindful and neutral in our postures, can you improve upon the current injuries that you have? Those are kind of the two fields I think that, or two questions that I would have if I wanted to further study and kind of determine how do we prevent and get to that threshold, prevent getting there so we're not permanently at a point where now you have to have surgery for spinal disc disease. And two is if you do start having signs of these disorders, musculoskeletal disorders, by the interventions we recommend, which Dr. Park's right, these are best practices. We haven't actually evaluated them to see if they really do improve upon it. Can you reverse some of that damage? Can you improve it?
Yep. And I hear what the two of you are saying is that we have such limited knowledge. What do we use as the outcome measure? That you have spine surgery, or is there something we can detect before that, either at the tissue level or with an MRI or a subjective questionnaire even that's a little bit more reproducible person to person? We just don't even know really what we're looking for yet as the measure of success or non-success. So this is a really interesting discussion. Of course, we're going to post this video of our discussion tonight on the OGS website, Instagram, so you can all watch it later or tell your friends to watch it. Really wanted to send a warm thank you to Dr. Park and Dr. Yurteri-Kaplan for taking time out of their evening to get on Instagram, in some cases to even learn to get on Instagram Live. So thank you all. We all learn a lot about social media in these exercises, and I just really wanted to thank both of you ladies who are so busy for talking about ergonomics, because it's a really vital topic.
Thank you so much.
Thank you for inviting us.
Yeah, absolutely. And please check out Dr. Park or Dr. Yurteri-Kaplan's research on both Urogynecology Journal and other things that they've mentioned, or other articles that they dropped names of in this talk, because there's some really cool literature out there that discusses this point. And thank you all for joining us, and I hope you all have a great evening.
Thank
Good
you.
night. Thank you.
On
Good
behalf
night,
of OGS and the Urogynecology Journal, I'd like to thank our speakers, Dr. Park and Dr. Yurteri-Kaplan, and our moderator, Dr. Meriwether, for taking the time out of their day for this Instagram Live interview. And thank you to all of our viewers who tuned into this event.
All right. Good night, Instagram.
Night.
Bye.